Assalamualaikum warahmatullahi wabarakatuh to all my students. So today I will talk about dental public health strategies. Okay, so what have come to your mind when I say that it's dental public health strategies? What strategies that we want? Okay, what strategies that we want for the prevention? Okay, so we go one by one. So in this topic, I will explain what's the example of dental public health strategies and the strength and limitation of each of the example. Okay. As we know, oral diseases, for example, dental caries, periodontal disease, can be preventable. Okay, and it's very common. So what is going on? Why this disease still happen? Okay, why this disease, the prevalence is still high? So it might be because the factors or the etiology factors for this disease are very complex, and it influences the health status of individuals and population. Some of the factors are beyond our control. Okay, some of that factors cannot be changed or cannot be modified by the health professionals, because, for example, the genetics, the biological factors, something like that. Okay, so the effective evidence-based preventive approach are needed to address these major public health problems. So according to Ottawa Charters, okay, there is a range of strategies that can be implemented in partnership. Okay, we cannot work in silo. We have to work with the local, national and international agencies, especially for the prevention. Okay, so the core of this public health approach is we need to empower our local communities, okay, to make them actively involved, to make them know how to take care of their oral health. The principle of the strategy design, okay, is similar to other oral health care planning. Okay, so we have to know the aim or objective of our strategy, right? What are we trying to achieve at the end of this strategy, and how to get there? Okay, the process to get it done. There is a few preventive approach that I will share with you all in this slide. Okay. So which oral health promotion and preventive approach that we should adopt? Okay, and why we have to choose the right approach? Okay, is mainly because of the scarce resources. Okay, usually we have a limited budget to run the strategies. Okay, we have a limited manpower, we have a limited time. That's why the right approach is we have to choose the right approach. And usually the oral health intervention is frequently duplicate. That's why we try to reduce the duplication of the intervention. So some of the reason is because some of the preventive program is inconsistent, okay, with the oral health preventive programs. Okay, now we go to the strategy approach. Okay, according to Jeffrey Rose, 1992, he divides the preventive approach into two distinct groups, which is the whole population approach, and the second one is the high risk approach. So the first approach is the whole population strategy. Okay. So the aim of this whole population strategies is to target the whole community. alright, to control the occurrence of new disease in the population. So we didn't, for this approach, we didn't go to individuals. We go to the community as a whole. Okay, so it's directed at the whole population, irrespective of individual risk level. So as we know that, for example, the dental caries, there is a low risk group, moderate risk, and high risk. But for this whole population strategies, we capture the whole population. Alright, we didn't left anyone behind. Okay, what is the example of this whole population strategies that you can think of? Okay, so for maybe for the dental, okay, that maybe I can share is the water fluoridation. Alright, because for the water fluoridation, for example, in Malaysia, we give to whole population. We didn't select which person that we want. Okay, we give to whole. So for the whole population strategies, usually we target to the normally distributed disease. Okay, if you can see the graph below, okay, this is what I mean by the normally distributed disease, a bell curve graph. Okay, because in this normally distributed disease, everyone has some disease. Okay, so assuming that the decision is made to reduce the overall disease burden. Okay, as I said in the previous slide, I said the whole population strategies, the example of the whole population strategies is the water fluoridation. So the water fluoridation, we give to all that stay in Malaysia. So we try to reduce the disease burden for the whole. Okay. So the choice is between trying to reduce everybody's exposure or to select a subgroup of the population. Okay. So this is more effective to work with the whole population compared to a different subgroup. Okay, so this is the example of the normally distributed graph. Okay, if you can see the x and y axis, the x axis represent the risk of the disease, and the y axis is the frequency of the disease. So we give the example for this one is dental caries, for example, right? So the original graph is the A graph. So you can see the bell curve graph here. So this is the midpoint. So you can see that the average risk of the disease is higher. Okay, it's here. Alright. So by giving the intervention, the whole population intervention to this group, for this population, alright, we want to target to shift the graph from A to B, okay, to this graph. Alright, so if you can compare between the A, right, the A graph into the B graph, which one is lesser risk? Okay, this one A here, okay, the risk is higher is compared to the B graph. So by having, we give the water fluoridation to this group, okay, we want to shift from the A, the risk at the A point to the B point, okay. So hopefully at the end of the water fluoridation example, so the curve, okay, the graph become here. So we want to shift the whole population, okay, the whole population that stay at the A be shifted to the lower risk, from the high risk group towards the lower risk group. Okay. So we want to shift from the harmful environment, the A environment, to lesser harmful environment, the B environment. The whole population strategies, okay, there is a strength and limitation. Okay, for the strength of this whole population strategies is radical. Okay, because we want to remove the underlying impediments or root factors by addressing the social and political factors. And the approach itself is powerful because by shifting the population distribution will affect many people. As you can still remember the previous graph, okay, we shift from the A, okay, the A graph to the B graph, okay, from the harmful environment to the lesser harmful environment. So it affects many of the people that under the graph, okay. So the third strength is the behaviorally appropriate. Okay, because in this approach, we want to change the normal behavior of the population. Okay, from the normal behavior to the accepted behavior for the good health. Okay, and the next one, the limitation. Okay, of course, in every approach there is a limitation also. Okay, so in terms of acceptability, it may be not acceptable to the population, and they may not be willing to make the personal change. Okay, and in terms of feasibility, okay, other pressure in the society may make the changes very hard to bring. Okay, maybe the health, okay, the health pressure is more is their priority, or the financial, okay, so they take lesser priority for the oral health care. Okay, and in terms of the cost and safety, okay, the cost we have to pay immediately, okay, to run the strategies, to run the intervention, but the benefits are more long term. We cannot see the short term effect by having this whole population strategies. Okay, so instead of the water fluoridation, there is some other example of the whole population approach. Okay, so if we give the health education or oral health education via mass media also is some sort of the whole population approach. Okay, and smoke-free environment. Okay, our government is promote the smoke-free environment. It's the whole population approach also. Okay, and then seatbelt legislation. Okay. Okay, this one targeted population approach is quite similar, but it's not really the same like the whole population approach. We targeted. Okay, so this one on the principle that some group of the population are the greater risk compared with the whole population. Okay, so not all people who are at risk of the disease will be included within the target group. So the variety of intervention can be used, for example, the clinical intervention, environmental approach, or developing a community and individual skills. Okay, this targeted population approach is quite useful approach where we have limited of resources. Okay, and when we have one group, okay, maybe in the large group there is a subgroup, and the one group is clearly more disadvantaged than another. Okay, so when we find this kind of situation, we can use this targeted population approach. So it reducing the inequalities in the health. Okay, it also differs from the high risk approach that I will teach you later. Okay, because not every person, within the targeted group is at higher risk. Okay, for example, maybe we go to one area, we go to the one area, and we found that to have much higher level of dental decay. Okay, maybe one subgroup of that area have dental decay, high risk of dental decay. So the school identified, and the decision is made to introduce a fluoride toothpaste brushing scheme. Maybe every week, every day, the student have to brush their teeth before they entering the class. Okay, the next approach is the high-risk strategy. The aim of these high-risk strategies is to focus on individuals, okay, at high risk who have been identified through screening tests. Okay, to be effective, the screening test must have an acceptable level of sensitivity, specificity, and predictive power. Okay, so once the person have been identified, the high-risk individual at the tail end of the disease distribution are then offered the preventive support. So for the high-risk strategies, the treatment, we only give a treatment only to those at greatest risk. Okay, so rather than using the whole population strategies or part of it, okay, the targeted population strategies, only specific individuals are identified by a screening program. Okay, so if you still remember the whole population graph, okay, here the population whole population graph, we want to shift from A environments to B environment. Okay, here we want to shift the harmful environment towards the lesser risk. Okay, this is the whole population strategies. And now for the high risk strategies, usually the population we divide into a few groups. Okay, here is the low risk group. Okay, and the next one, okay, at the middle, okay, here is the moderate risk, and at the end, okay, this one, this is the end tail of the graph. This is the high risk group. So for the high risk strategies, we only target for this group. Okay, for the high risk strategies, before we categorize the person into a high risk group, we have to do a screening. So what is the screening? Screening is a presumptive identification of unrecognized disease or detect by the application of tests, examination, or other procedures which can be applied rapidly. So according to Wilson and Jonger 1968, they list 10 principles of screening. Okay, so the first one, the condition, okay, the condition or the disease should be an important health problem. Okay, the second, it should be an accepted treatment for the patient with recognized disease. The facilities for diagnosis and treatment should be available. Okay, and the disease also, it should be recognizable in early symptomatic stage. It should be suitable examination. There should be acceptable to the population. Alright. Then the natural history of the disease should be adequately understood. Alright, before we do the screening. And we should also agreed policy. There is an agreed policy on whom to treat as a patient. Okay, and then the cost of case finding, including diagnosis and treatment of patient diagnosed, should be economically balanced in relation to possible expenditure on medical care as a whole. And the case finding, okay, whoever that we notify as a case should be a continuous process and not a once and for all project. So for the high risk strategies also, there is a strength and limitation. Okay, the strength of high risk strategy, the intervention is appropriate to the individual because this is individual approach. Okay, So it avoids the interference with those who are not at special risk, okay, because we only target for the high risk group. So it also enhances the subject motivation. The patient will become motivated to go to get to seek the treatment, and it also enhances the physician motivation because the physician or practitioner, okay, they can see the result immediately, and the cost effective use of resources, okay, because we know that by having the high risk strategies, one-to-one treatment, so we can get the immediate result, okay, and the selectivity improve the benefit to risk ratio. And of course, for the high risk strategy also, there is a limitation of this approach because the prevention of this the prevention becomes medicalized, okay, and then the success is only palliative and temporary. Yeah, it's not a long term, okay, it's not a long term success. And the strategy also is behaviorally inadequate because by having this high risk strategy, we didn't change their behavior, okay, we are not change the norm of the population because we target the individual, okay, and then the poor ability to predict the future of the individuals because after we do some treatment or we give some prevention to this high risk group, and then we doesn't have the continuity. And the problem of feasibility and the cost, of course, even though it's cost effective, okay, however the high cost because in terms of sustainability, and the contribution of this approach to the overall disease control is quite small. The example of high risk strategy is fissure sealant, okay, topical fluoride, or chairside dental health education. This is some of the programs that have been conducted by Ministry of Health, okay, school-based fissure sealant program. Okay, this is one of the high-risk strategies. Okay, the school-based fissure sealant program is a clinical preventive school-based program that target children at risk of occlusal caries. So it was implemented nationwide in 1999. So in 2003, the guidelines were reviewed, and PEED and fissure sealants proved to be effective in preventing occlusal caries in children. So the effectiveness was related to the retention rate of sealants. Okay, the next approach is common risk factor approach. Okay. So oral health must always be included in general health messages and action. So for the common risk factor approach, they address risk factors that common to many chronic conditions. Okay, common risk factor approach recognize that chronic non-communicable disease, for example, the obesity, heart disease, stroke, cancer, diabetes, and other disease, share a set of common risk factors. So as these causes are common to a number of other chronic diseases, adopting collaborative approach is more rational than disease-specific approach. Okay, for the key concept of the integrated common risk factor approach is by directing action toward this common risk and their underlying social determinants. Okay, so the benefit of this common risk factor approach, it promotes general health by controlling a small number of risk factors. So instead of focus on the disease itself, we focus on the risk factors, what the causes of the disease. Okay, so this common risk factor approach also may have a major impact on a large number of diseases. Okay, because one risk factor may cause a lot of diseases, and this approach also have lower cost because it's like kill two birds with one stone, for example. Okay, and greater efficiency and effectiveness than disease specific approach. Okay, so if you can see this figure here, alright, the left and the right one is the risk factors, okay, and then this is the disease. So traditionally we always target the disease, okay, but with this approach, common risk factor approach, we target the risk factors. For example, we want to target, okay, we want to alter the diet, okay, for example, the risk factors is diet. Diet can cause obesity, diet can cause cancers, diet can cause heart disease, diet also can cause dental caries. So with this approach, the common risk factors approach, okay, we try to control the risk factors. We try to reduce sugar. We want to try to reduce salt maybe, okay, in terms of diet. So with this approach, we can modify, okay, we can avoid many of the diseases that involve with the diet. And the next one, maybe the risk factors of tobacco, okay. Alright, maybe tobacco, you can see here, the tobacco. Tobacco can cause a lot of diseases, okay, can cause cancers, it can cause heart disease, it can cause respiratory disease, okay, and it can cause the periodontal disease. Alright, so by having this approach, we just target the risk factors that can prevent some of the diseases. So many has problem or disease share common risk factors, okay. For example, eating unhealthy diet which is high in fat and sugars, low in fiber, can lead to development of obesity, coronary heart disease, diabetes, and dental caries, okay. So health promotion strategies, okay, offer this common risk factor approach the potential of effectively dealing with a combination of health problems together. Some of the risk factors cluster in groups of people. Okay, by changing one of the factors may influence the others. For example, the smoking, heavy drinking, and poor diet tend to cluster in the same people. Okay, so changing their smoking behavior may affect the other behavior. The characteristic of major oral diseases, okay, they are chronic, okay, high potential for recurrence. Cure is impossible without drastic changes in behavior and lifestyle. And they can be easily prevented. Technology and methods are known, simple and available, but it's not effectively applied, okay. And serious impact on everyday quality of life, although it's rarely fatal. And it may share the same root cause. Okay, so this is the healthy lifestyle campaign that have been conducted in Ministry of Health. Okay, if you can see there is phase 1 and phase 2. Okay, in the phase 1, it started in 1991 to 1996. It's usually is disease oriented. Okay, if you can see here 1991, cintailah jantung anda, love your heart. Or 1992, AIDS pembunuh. Okay, nanti 1996 is diabetes, prevent diabetes. So it's the earlier years, okay, the earlier years is much more on the disease oriented. And after that, okay, in the phase 2 here, okay, it started in 1997, 2001, it started to have the behavioral oriented. Okay, you can see here, healthy eating, okay, for the good health, exercise, prevent injury, okay, adopt healthy lifestyle, okay. So in the Ministry of Health also, they towards to the behaviorally oriented approach. So this is the campaign by the government also, the reduction of sugar consumption campaign. So this is one of the approach, common risk factor approach by target the risk factors. So this campaign is launched on 1st December 2009, which the motto satu sudu sudah cukup. Okay, stop at one, less is better. So the aim of this campaign to increase public awareness in reducing sugar intake for maintaining a good health. Okay, so in 2009, Malaysia is the 8th highest sugar users, okay, in the world. Okay, so average consumption of population in Malaysia is 26 teaspoon per day. Okay, it is very much higher compared to the recommended teaspoon. Okay, so what is the average what is the recommended teaspoon for adult? Okay, if you still remember, it's 12, 12 teaspoon. So if 12, this is a double, more than double of recommended sugar intake. So major risk factors for chronic disease are smoking, diets high in fats and sugar, diet low in fibers, fruits and vegetables, alcohol consumption, injuries, and sedentary lifestyle. This is the advantages of the common risk factors approach. It decreases the overall level of disease to manageable level. Okay, that level that we can manage. And it also doesn't concentrate entirely on high risk individual because we focus on the risk factors, and it tackles the underlying causes of the distribution of the disease rather than the causes of the incidence of the disease in individuals. The advantage is this approach also, there is more success than other approach that are limited to one disease. Okay, so better use of limited resources that are available, and thus it's better economic sense. Population-based prevention usually is difficult to undertake, especially measuring its success by examining changing pattern of disease is quite hard. So other type of evaluation are easier. The success of the process can be examined by looking at how many people participated in a screening program. What has happened to cigarette sales following a health education campaign? Okay, so in terms of evaluation for the prevention program, it's quite hard to assess. Okay, so this is some more of health promotion activities that conducted by Ministry of Health. For the oral cancer, okay, this is some of the program that have been conducted. The prevention and early detection of oral pre-cancer and cancer program. So the targeted group at risk was first launched in 1996, and the aim of these programs to raise awareness on risk factor associated with oral cancer and to detect early sign and symptom of oral cancer. Okay, so this is some more activities in terms of disease condition. Okay, the issue safety, environment, tobacco control, the lifestyle. Okay, to improve the healthy lifestyle. Okay, in terms of setting a good workplace, safer home, safer schools, something like that. Okay, and this is for example, last time we have a tak nak merokok. This is some of the campaign. Okay, and I handle my stress positively. Okay, so for the National Tobacco Control Program, the legislation, the control of tobacco product regulation in 1993, okay, they have a price measure that increase the taxation, okay, have the smoking cessation program, the smoke-free policy, okay, smoke environment, and there is advertising, okay, advertisement about the tobacco advertising ban, and counter advertising. Okay, they try to limit. This is a national tobacco control program. Okay, so Ministry of Health also have a dedicated quit smoking clinic, and they give a counselling for the smoking, for the diet, for the stress. Okay, to the individuals, to the groups. There is a pharmacotherapy also, motivation. Okay, by using a dental care, lung function, blood analysis, and then they give a referrals. Okay, and they also have a clinical practice guideline, the assessment of tobacco use. Okay, the clinical intervention of brief clinical intervention. Okay, because the current situation in Malaysia right now is we have a lot of vapors, okay, and it's not only for the male and female also, vape and smoking. Then in terms of settings, the health promotion in the settings, healthy cities, okay, health promoting school, okay. So Ministry of Health also working with NGOs in health promotion, okay. There's a smart partnership between ministry and NGOs, okay, with the specific health NGOs, for example Nabatna, okay, the health related NGOs, okay, Bulan Sabit Merah and so on, umbrella organisation, okay. So as for the conclusion, okay, the preventive strategy need to be based on a good assessment of the problem. Yes, because before we do any kind of strategy, we have to assess what's our problem, okay. And evaluation of the intervention are available, okay, and we have to careful consideration of the most appropriate method for delivering the desired intervention. Okay, so as for overview, alright, we have the whole population strategy, high risk strategy, and common risk factor approach. Okay, and under of the whole population strategy, we have a targeted population strategies. Okay, but this is the three main strategies that you should know. Okay, so this strategy will involve in the promotion. Okay, in the promotion and also the prevention of oral diseases. Okay, so I think I cover all of the topics regarding the dental public health strategies. So I hope it can give you all some insight of the strategies that you can use in the future. Alright, so if you have any question, you may email or you can text me your question. Alright, with that, thank you. Assalamualaikum.